First, though, I was going to provide an overview of venous thromboembolism. What is it, and what is the pathogenesis, our modern concept of that? And these are just a few disclosures. So to, I guess, go over terminology first before I go into the discussion of pathogenesis. I'm using the term venous thromboembolism to designate any deep or superficial vein thrombosis or pulmonary embolism. It includes those clinical conditions. And if one considers deep vein thrombosis and pulmonary embolism together, about 900,000 Americans each year suffer from one or both of these events. Fatal P is estimated to occur anywhere from 60 to 100,000 patients each year, depending on the survey you look at. Post-thrombotic syndrome affects anywhere from 20 to 50% of patients who suffer a deep venous thrombosis within 2 years. And recurrent events, either DVT or P or both, will occur in about 40% of patients within 10 years of their initial event. These are some epidemiological data from the Worcester, Massachusetts Epidemiology Project that has followed patients in Massachusetts in a 10-hospital system over many years, as you can see, with ongoing enumeration of events. And as you can see, despite the fact we spent a lot of time focusing on DVT-P and how to prevent it and treat it, that the event rates for these conditions have continued to rise through the last time they assessed data, which was back in 2009. And so this remains a very important clinical problem we need to focus a lot of attention on. Now, anytime you talk about deep vein thrombosis, pulmonary embolism, venous thromboembolism, I think it's always important to acknowledge our forebearers, the great thinkers in history have thought about this, and you really can't talk about it without mentioning Rudolf Virchow, who was a pathologist back in the 19th century in Germany, who first came up with the concept of pulmonary embolism. And in his honor, the main, I guess, umbrella terms or pathogenic states that lead to clot formation has been designated as Virchow's triad, and you can see a depiction of that on the slide. That any clinical states that result in stasis of blood, or result in vessel or vascular wall injury, or cause hypercoagulability of the liquid portion of the blood, they, in isolation or in combination with each other, can lead to the development of a deep vein thrombosis or pulmonary embolism. Now, over the years, we've learned a lot more about what causes DVT-PE, and so a number of different risk factors have been identified. This slide contains some of them, is by no means all-inclusive, but there are a number of inherited risk factors that have been identified over the years, and a number of important acquired risk factors that are very common, such as increasing age, surgery, cancer. All these are very common risk factors. And what I'm going to do over the next few slides is to look at the impact of these risk factors on the absolute risk of DVT-PE, and then look how they collaborate in a multi-causal model to result in a deep vein thrombosis or pulmonary embolism. So this is a graph that I compiled data from, as you can see, from a number of different publications that have looked at the relative risk of deep vein thrombosis or pulmonary embolism associated with different clinical conditions. And as you can see toward the left end of this bar graph, the biggest contributors, the highest risk factors for DVT-PE are surgery or multi-trauma, severe trauma, that are associated with very high rates of DVT-PE in the absence of any prevention therapy, that raise a risk of someone that experiences these to over 100-fold over what is experienced by the baseline, by the general population. Then you see a number of other clinical conditions, cancer, as you can see, associated with significant risk, and then the most potent of the inherited risk factors, antithrombin deficiency, that Dr. Tarantino will be discussing in a few minutes, is also associated with significant risk, and then various other inherited risk factors and acquired states such as antiphospholipid syndrome, immobility, as you can see, which is common among hospitalized patients, and then even more common associations that are much lower as far as their risk, risk of venous thromboembolism, such as travel, that long-haul travel has also been discovered to be a risk factor for developing deep vein thrombosis and pulmonary embolism. So this is from the Mayo Clinic group and their studies in Olmsted County, looking at what is the risk of deep vein thrombosis or pulmonary embolism as our age increases. And as you can see, as we age, particularly as we hit the mid-50s and up, the risk of DVTP goes up dramatically. And some of this is due to age-related changes in the blood. Other is due to the fact that we develop diseases that put us at risk. We have to have surgery, we have pneumonias or illnesses that cause us to be hospitalized. So age is an important risk factor that always needs to be considered when seeing patients that might have symptoms that relate to a DVT or PE. As I showed on a couple of slides ago, surgery is a very important risk factor. This is data from the Million Women study that was done in the United Kingdom, looking at over 1 million women and their risk and DVT or PE events that occurred over a 2-year period, and looked at the risk associated with either inpatient surgery that you see in the blue line or day case or ambulatory surgery that you see in the red line. As you can see, these are in the weeks following a surgical procedure, there's a huge increase in risk, particularly for patients that have an inpatient surgical procedure that rises above 100-fold the relative risk experienced by the general population, and then gradually over time after the hospitalization, this risk dissipates, although it takes actually many months for the risk to go back down to the baseline. You also see that in the red line that even ambulatory surgery puts patients at risk for developing a deep vein thrombosis or pulmonary embolism. Medical hospitalizations also increase risk. This is from administrative data from the U.S., and as you can see, these are event rates on the days since hospital admission, that every day that passes after a hospital admission, the risk of DVT or PE rises out to about 180 days after admission does the event rate start to plateau. So patients remain at risk after a medical hospitalization for an extended period of time beyond that hospital stay, which is why some have suggested that extended prophylaxis should be considered at especially high-risk patients. Now, this is one of several slides where I'm going to try to pull this all together quickly before we move into a more detailed discussion of antithrombin deficiency. These slides are largely based on, I think, one of the landmark papers in the literature that was written by Fritz Rosendahl, published in 1999 in The Lancet, where he shows that how you have inherited risk factors, you have intrinsic risk factors, and then you have extrinsic risk factors. And it's the combination of intrinsic and extrinsic risk factors that combine to create what your risk of a thrombotic event is. And that there is a thrombotic threshold that when you have an accumulation of risk factors of significant degree, that will push your thrombosis risk above this threshold and triggers a clinical event. And so here we have a hypothetical case of an orthopedic surgery in a patient that's 50 years of age. You see his baseline risk very low, but increasing with age. And then as you can see with my arrow, he has his surgical procedure, and this orthopedic surgery, this major surgery, the immobilization, the tissue trauma, activation of the clotting system, that is what puts him over this thrombosis threshold, and he develops a deep vein thrombosis. And then after treatment, this risk then goes away, which is typical of patients that have a significant risk factor like surgery. It's a time-limited risk factor, and then with treatment goes back down, and then he resets to where his risk is at that particular age, although, as you can see, increasing over time with age. Here's another hypothetical example. You have a 23-year-old who happens to have factor V Leiden, so you see her risk is a little bit higher than our previous example. Then she starts on an oral contraceptive in those first few months. On the oral contraceptive, her risk rises above that thrombosis threshold, and she suffers a thrombotic event. And that once she stops the oral contraceptive, gets treatment, her risk goes back down, although it's still rising over time, because she still has that ongoing risk factor of factor V Leiden, but is no longer above that thrombosis threshold. And then finally, I'll end with a case that Mike's going to spend a lot more time talking about the specifics of antithrombin deficiency, but patients with antithrombin deficiency are generally thought to have a much more thrombophilic state than patients with factor V Leiden. And so you see here, this is a case of an unprovoked DVT in a 25-year-old that because they have this baseline very hypercoagulable state of antithrombin deficiency, their thrombosis threshold, they're much closer to the thrombosis threshold, and that they breach this threshold with, in this case, without any provoking event because they have this potent thrombophilic state, antithrombin deficiency. And so I think that when we think about thrombophilia, you have to think about what patients' risk factors they have that are intrinsic, such as antithrombin deficiency, and then what additional environmental risk factors are present, and try to get rid of those so you can reduce their risk of thrombosis going forward.